So we move to head and neck cancer. Surgeon Mike Fardy, President of the British Association of Head and Neck Oncologists, specialist organisation for head and neck cancer treatment from 2015 to 2017. So he's got some time to go yet. And a patient, is that right? Just you. But I think you may mention a patient or two. Thank you very much indeed. Mike.
Ian, thank you very much indeed for this kind invitation. I'd also like to thank the UK Passport Office and Border Control for allowing me a visa to come over from Wales. Unfortunately, it's only for 12 hours, so I'm hoping that John will tailor Ian Hutchinson's enthusiasm. He could stand here all day, as we all know, waxing lyrically, but we must pass on. This is another famous Welsh person, Catherine and myself, standing there having our photograph taken. The one thing about it is you just look at their faces and they are just beautiful people. It's very easy for all of us, and I stand here as President-elect of Barno, which represents all the surgical specialties plus the oncologists who treat this condition. And it's very easy for us to wax lyrically about how great we are and show you slide after slide of our fantastic results. This is an example of an oral cancer. That's an example of a lip cancer. And these patients walk into the clinic. But again, it's very, as I said, very easy to talk about how good we are, but I think we really need to be honest with patients. And we really do need to talk about the principles. Resection, we need access, we need to be able to clear the tumor. Now, a lot of people, you'll hear people talk about curing disease. Now, correct me if I'm wrong, despite what surgeons believe, we're not God. We can clear disease. Do we cure it? I really do not know. And I really wish from the bottom of my heart people would stop talking, surgeons and oncologists, about curing disease. We do not cure it. Can we clear it? And I think that's important. And we also need to preserve vital structures. In days gone by, in the Cryle, who was the pioneer of head and neck cancer surgery from the States, used to take, when he was doing cancer operating, would take everything from the base of your skull down to your clavicle. That was fine. You cleared the disease, but the morbidity of it was quite enormous. People couldn't move their arm very well, and over time had terrible shoulder problems. So in clearing the disease, yes, you've achieved that, but you've left the patient with terrible morbidity. You want to be able to reconstruct them, and as Simon quite eloquently showed, you need to be able to provide them back with function and cosmesis. And finally, we've really only now come more into this, is quality of life. There is little point in taking somebody's head off, putting it back together, if they're never going to leave the house. I did have one patient who only ever came out in an ambulance straight to the clinic and back again. And you think to yourself, what have you achieved? Yes, you've cleared their disease, but you've achieved nothing. Really, as Barno, we're very proud and privileged to be able to join with Ian in this fantastic group to look at data. We need to collect data because, as I've said, you'll find that all surgeons will stand up in front of you and stand up in front of us and say how great they are and what the fantastic results they've achieved. You will rarely, if ever, see people stand up showing their complications. And let's be honest, we all have complications. Things go wrong. We don't intend them to go wrong, but they do go wrong. And we have to be honest. Now, do you tell the patients they're going to go wrong before? No, I think if you're like America where you have a huge tome to sign before, that frightens them to death. They are petrified as it is, but you do need to be honest. And to me, I think the biggest hurdle in really the development of treatment are the consultants themselves. You can say in front of the Deputy Medical Director that management are a problem. Well, they are actually, but we'll park them aside. Finance is a problem. Of course it's a problem. You know, we've only got a limited amount of money. You could pour billions into it, but you'll still always have problems. You'll still have people complaining. But the biggest problems are the consultants, because they are kings in empires. They are on the throne. Listen to what I've got to say. And we're not shy at coming forward, promoting ourselves. We all stand up, and we are the best. This is why this organization is so good, in that we're going to get data. Now, you see, we can reconstruct any part. Now, we can take wide amounts of tissue from anywhere. So where you've got big composite defects, half the face, all the jaw, most of the neck, you can take tissue from here, there, and everywhere. You can take it from his arm, you can take it from his leg, the abdomen, etc. So we can do that. But what you worry about, of course, is have those surgeons actually done a lot? Because if they've only done 1 or 2 cases, who's controlling them? So you don't want this situation where they get the book out at the end of the table or scroll the internet. Of course, as I said, quality of life is important. You look at this chap. This was an 80-year-old man who he lost his wife in the 1930s, never went out, and he presented with this squamous cell carcinoma. The treatment of choice for this, without doubt, is resecting his ear. But he didn't want it. Eventually, we had some data. We showed him that this is what we could do. We could take his ear, put some implants in, because we had the data to show him that if we did this, we could make him a prosthetic ear. And he was absolutely delighted about it. This is the first time this man had gone out in years. And what he used to do, bless him, was go to a local restaurant in the Vale of Glamorgan. And this poor young girl, as a waitress, would come up and he would chat away to her. And then he's, oh, sorry, my face. And he'd scratch his face, pretending. Next minute, he'd drop his ear into this girl's hand. To him, this was fantastic. This is a poor chap. This is a poor chap who presented. And if you look there, what's wrong with him? What's wrong with him? I'm sorry about that. There we go. What's wrong with him is that he's got a squamous cell carcinoma of this nasal septum. The treatment of choice is to remove his nose. And this is what we did. We showed him the data. We had the data. And we showed him that we could make him a false nose. And he's back out into society and he's enjoying himself. We, as surgeons, and you've seen the recent thing in the papers about surgeon outcome data, I'm not going to stand up here promoting it or saying it's a bad thing. It's important to have that data. It's important. But what Ian has promoted, and I've been lucky to sit on his coattails with it, is that we are pushing forward a national database, and we've got the plastic surgeons, and we're looking at a FLAP database. We'll have all these figures so that over a huge bulk of patients, we're talking thousands and thousands of patients, and it's so important then that it'll help educate patients, it will actually help the managers in looking how we develop services, and it may name and shame a few surgeons, which is never a bad thing. What it'll also help, I suppose, is why is oral cancer spreading? Now, we all know about alcohol. It has been mooted to me, whether it's right or wrong, that the biggest cause of the increase in head and neck cancer was Emily Pankhurst. If they'd have kept that lady on the railings of Buckingham Palace, we would not have had emancipation. We would have not had women going out enjoying themselves and increasing alcohol intake, and therefore the amount of oral cancer would not have increased. Yes, not quite the reaction I got when I said that to a bunch of hygienists who nearly on one came and attacked me on the stage. But the other, of course, major factor is smoking. That is a huge factor. The other one more recently is HPV, and we know about Michael Douglas, and I was privileged to stand in the audience in an international meeting recently in New York, where he spoke very eloquently about his experience of getting laryngeal cancer. We did a little bit of work, and again it was a small amount, comparing 2 cohorts of patients from 65 to 75, looking at the fact that, and the message really is that the total deaths have got better, but the distant metastases have got smaller. They used to be 20%, they've got 0%, but they've got now to 20%, so that we're actually clearing the disease, but they're dying of distant metastases. And we need to look at that. We need to understand why we're doing it. Our survival has also got better. But again, we need to look at it to see whether we're actually doing the right surgery. So in conclusion, I think that head and neck cancer is by far and away the most socially isolating cancer. It affects, as Ian said, speech, appearance and hearing. It's common and it's very life-threatening. What little surveys we've done through BOMS and Barno, there's variability, and this is where NFORC hopefully will pull all this data in, and it'll give us much better idea of where our quality of life and how we remove the disease. Patients want it, we want it, and I think Barno with NFORC will help hopefully improve the situation, because in the end of the day, ladies and gentlemen, beauty is in the eye of the beholder. Thank you very much.